Brånemark came to Israel, and I had the honor to present this case where I have taken a block and inserted it into the sinus. He was not impressed at all. He just looked at it and then he said, "Soon we won't have to do sinus lifts." Hello, my name is Dov Kischinovsky. I'm an oral maxillofacial surgeon, and I'm very honored being invited by GDT Dental Implants to tell you something about my professional life. I've been in the profession for about more than 50 years. I started studying dentistry in Hadassah Hospital in Jerusalem, and later on I went into specialization in oral and maxillofacial surgery, also in the same hospital. When I finished, I taught a few years, then I opened a surgical unit in another hospital in Israel, in Bolton, and later on went into private practice. In private practice, that wasn't just in the years of the beginning of something coming on the market called an implant. Yes, now everybody knows what an implant is, but no one knew about what it was. It was something very unusual. And when I heard about that, I in fact went to a course in Belgium with Professor Brånemark, Professor Stenberg, and there I for the first time saw what you could do with implants. This was especially a course about rehabilitation of severe oncological cases, so it wasn't really a beginner course. But for me it was the beginning. And I went back to my clinic and started to do from single implant to more implants, lower jaw, upper jaw, and in the end, of course, I got to this very difficult, fully atrophic cases where I had to give a solution. So what was the solution in those years? That was grafting, yes. I had an anesthetist in my clinic, and I used full horseshoe grafting in the upper jaw to rehabilitate the upper jaw with implants. I of course took courses where I could find people who also are specialized in this field. It was in fact in Umeå in North Sweden. I went up there, and there they had a special unit for grafting. And I started to do grafting in my clinic, although, you know, it was difficult for the patients. When you take a graft from the hip, you know, the patient can't play tennis. I didn't have too many patients playing tennis, but I did have one. And she was really complaining about that, not about the operation. So it was a real challenge to do this very, very life-changing cases, you know, and give them teeth back by this big operation. Like when I have a graft, you know, especially in the upper jaw, you have to be without anything for months, for half a year, until there's integration of the bone, and then you can make the implants. I didn't know you could make a medial implant into the bone. That came later on. But this was a very, very difficult period for the patient, you know, to go through all this to have teeth. One day, Professor Brånemark came to Israel, and I had the honor to present this case where I have taken a block from the hip and inserted it into the sinus and inserted 4 implants immediately. And I thought that was a great case to present to him. But he was not impressed at all. He just looked at it and then he said, "Soon we won't have to do sinus lifts." And I took those words, and they followed me in the following years, and I was really checking up on Brånemark. What was he talking about there? And after he had done about 10 years in his own private clinic of Zygoma, they came on the market. So immediately when they came on the market, I went to Berlin. There, Professor Malavet, she did her first courses, and there I saw for the first time, you know, that you had a CT scan that you can turn around and you can see the backside of the patient. Amazing. And then there I also learned about the zygoma implant. Now, of course, when you learn, it's not enough. You have to train. And I went back home and I started to do them freehand. And then in year 2001 or 2, I went to a conference in Athens, and there was a booth, and I saw there was something of, surgical guides. And then I got into that in fact I could create a surgical guide for my zygoma implants. So they led me to do mucosal supported zygoma surgery. I also started to use it in all my other cases, but that's another story. But I started to develop this treatment plan with zygoma and pterygoid implants done by surgical guiding with an acrylic guide. And I did that for many years and developed different sorts of guides. Then the quartz zygoma suddenly came on. People, my colleagues started to do that, and I started to do the quartz zygoma too. And it developed into also having guide for quartz zygomas. When you ask me such a question about all in 4, all in 6, first of all, this is the part also of the non-grafting development, that this all in 4 became so popular. Now, I did not do all in 4 because I called it all in 4 or none in 3. What do you do if one failed? So I always developed anterior implants together with the pterygoids, so it became always all in 6. But if I had the anterior wall of the sinus more backwards, I would do all in 6. I mean, it's all a matter about stability and load distribution, besides the anatomy, and the bone density. All these factors you have to take into consideration when you make implants, especially, of course, in the upper jaw. So if you are not 100% sure about that you have these factors, then you are not even 100% sure about the predictability of your case. So I did more than all in 4, but all in 4 in the lower jaw is of course very successful, as the bone there is very concentrated and much stronger bone. So you can of course do that, and also in the upper jaw. But in my armamentarium and my setting in my clinic, I only made all in 4 if afterwards there was a bar on the other 4, connecting them 4 together, and then an overdenture. So that was my philosophy of having more implants to be able to make a bridge, and that's in fact got me into making zygomatic implants. Okay, so now when you ask me about how do we solve the problem of, the tilted implants, I mean, today we make tilted implants like this, we make like that, we make in the nasal, we make in the pterygoid, even without zygoma, which of course also is tilted. So how do we solve this problem? Prosthetically, we have to have the path of insertion for doing the impression, which is today, of course, mostly is done by intraoral scanning. But anyway, they have to be perfect. How do we do it? So we use the multi-unit abutments. They come in different degrees of 17, 30, 45, 50, 60 degrees, which should solve most of the problems, but not always. So here we can use the scanning, and the CT scan, the CBCT, and plan it exactly on our computer how we want the multi-unit abutment to be placed according to the teeth we want to build. If they want them to be in the cingulum, we can also do smaller corrections of the implant in the same time. So for that we need, in fact, the CT scan and to do the exact and the best planning. I mean, in my opinion, there's many more advantages than disadvantages in using, this surgical a guided, the planning for doing the prosthetics, It'll be, of course, much more accurate when you do it by sitting and working home on your computer and planning the implants and the multi-unit abutments together to get the right prosthetics. So we both have the CBCT scan of the jaw, of the bone, we have the bone quality, we have the bone volume, and then we have the denture incorporated into the CT scan. So in fact, we can put the denture on the bone and do all the planning like we're doing on the patient. So of course, it's much more efficient, and also for the patient, it's much quicker to do this than starting doing impressions and everything we have done in the past. So, and the most important thing is like that it reduces the errors that we make when we are working in the field. If you already have done it before on the computer and you can transfer your plan onto the patient, this is a great advantage. The disadvantages may be that we have to be clear that we have a very good CBCT, because that's our base of working, and we have to have a very good intraoral scanning and so on. So we use that as the basis for our plan. But I think we can solve this and have much less disadvantage of this case. It could be also more costly, I don't know. I'm not so sure about that. Well, asking me this question about what I think if the future should be digital, I'm a digital-minded oral surgeon. For 20 years I've been using digital planning, of course, both for the implant and also lately for the placing the prosthetics right. Although I started as a surgeon, my biggest concern it was that the implant would go in and it will sit there and it will be osseous-integrated. And I must admit, although it's not very right to say, that I was much less prosthetic minded in those days. I wanted just the implant to stay in. So when the doctor came and said, listen, you make the implant, but it's explicitly on an angle that I can't build on it. And so I learned, that I also have to take the prosthodont into consideration. But today, definitely, in my opinion, of course we have to use all the tools we have in our hands. Why not to use all the benefits of digital planning? For me, it's obvious that it should be done like that. But not alone, not I as a surgeon should plan, but it's to be together with the prosthodont and together with the technician. So we have a whole team who can sit and plan together, even if we don't sit in the same country. I can sit in Jerusalem, and one can sit in Washington, and another person can sit wherever, and we can work together on the Zoom on the same case. So that really makes a very, very big difference, both for the people who are taking care of the patient, treating, both for the doctor and the prosthodont, the oral surgeon, and for the patient itself. Yeah, now when you ask about the difference of using 1.4 and 1.6, it's really a question which I'll take over to the prosthodont, as I already inserted the implant. But if you want a prosthetic built up like a full arch with less fatigue on the screws, of course, if you have a bigger screw like 1.6, you are much less fatigue and you have much more mechanical strength. So why is the 1.4 came on the market? Yes, because you have single units or single crowns or smaller bridges where you don't have so much space and where you need to put in an abutment with smaller abutment screw 1.4, and this is really solved by the problem by using a 1.4 unit instead of a 1.6. So, you have to take into consideration what are you rehabilitating, what do you want, a single tooth or you want a full arch. So as I said, a full arch 1.6, and if you only have a single tooth or a smaller restoration, you can easily work because you have less space with the 1.4.